Hey everyone, it's Katie Copeland. As you know, this is my case study presentation on back pain in a college baseball player. Here we go. Okay everybody, so the first piece of criteria we're going to hit is the case information, and I've inserted some hopefully familiar images for your liking. Enjoy! Alright, so general health and social habits. So my patient was a 21-year-old college baseball player, and he primarily played first base, and he is presenting with mid and low back pain. He exercises normally 5 to 6 days a week with the team. Currently, he is able to attend practices, but he's on relative rest due to suggestions from the doctor and athletic trainer. He is also right-handed, so he bats swinging to the left, and he throws obviously right-handed. Social habits include about 2 drinks a week. He lives in a fraternity house, and he's unemployed at this time. And he's also, as I said before, seeing an athletic trainer, but he hasn't seen much improvement, so that's why he was referred to physical therapy. In terms of emotional health screening, we do some intake paperwork at the evaluation, and I was also comparing that paperwork to the nurse's note in the documentation system. And we saw some inconsistencies with one of the questions. So that first bullet point there about having little interest or pleasure in doing things. On our intake sheet, he answered nearly every day, and he said no on the nurse's note. So we just addressed that in the subjective interview, and we came to the conclusion that it was just an error because he filled out our form digitally, and it was just an error with the button he pushed. So everything was good there. Systems review, so if we look at vitals, we have a good blood pressure at 117/74, a pulse of 64, respiration rate of 14, and a temperature at 97.8 degrees. So all those are normal, no red flags there. And musculoskeletally, he did have some imaging completed, and that was cleared, so no red flags there. And he has a BMI of 26.32, which does technically put him overweight, but all things considered, doesn't, consider body composition. So we'll just take that with a grain of salt. Family health history, personal medical, and surgical history. So in terms of family history, we just have a paternal grandfather with some hypertension, so not much there other than that. If we look at his personal health history, we have a history of a minor labral tear of his right shoulder, specifically a type 1 tear, 2 years ago, and that was conservatively treated with relative rest and physical therapy. So if we look at the 4 types of slap tears, over on the left, highlighted there, we have the type 1 injury. So according to this definition, we have a type 1 slap injury being defined as a fraying of the superior labrum without tearing off from the glenoid fossa. So most commonly, the labrum injuries occur superiorly, where the biceps tendon originates from the labrum, and then when it pulls at the labrum, like with overhead sports like baseball in this case, its origin can tear the top of the cartilage away from the glenoid, and this injury is known as a slap lesion or a superior labral anterior to posterior lesion. So knowing the history of this slap tear could lead you to some conclusions about some potential compensations in the spine that can occur in baseball motions, like such as throwing. So, potentially if he's limited in his shoulder or has the previous injuries to his shoulder, he's going to compensate in the spine in order to generate the same amount of force that he desires. Evaluation. So his cognitive status is completely normal. He's alert and oriented times 4. History of the primary problem and the mechanism of injury. So he's had no history of back pain prior to this injury, he says, and the onset was about earlier mid-January of this year. He says he was specifically performing shuttles at practice. He pushed off of his right foot to change directions, and then he felt a pain in his back and was unable to continue practice. So the way that he describes all the areas of the symptoms, he gestures near the T12L1 level and L4L5 levels, and then he states in his subjective interview that his right side is more painful than his left. However, it is not shown in this photo on the right. He describes his pain as more sharp and pretty constant, but he denies radicular symptoms into his buttocks or his lower extremities, which is a good sign. And also he denies any changes of bowel or bladder function. He also describes the behavior of his symptoms as constant, as said before. On the VAS, he says it ranges from about a 2 out of 10 to an 8 out of 10, and it's worse in the morning when his back is more stiff and he hasn't moved at all. In terms of symptom quality, like I said, he describes it as sharp. Aggravating factors include higher intensity activity, like swinging a baseball bat, which involves rotating to the left, right-handed throwing, and sitting for longer periods. Easing factors include heat and e-stim prior to practice that his athletic trainer has been applying, and also rest. If you look at the top right corner, you can see more specifically where the areas are of his symptoms. Cognitive status is completely normal. He's alert and oriented ×4. History of primary problem and mechanism of injury. So he's had no history of back pain prior to this injury, and the onset was around earlier mid-January this year. He says he was doing shuttles at practice, and then he pushed off of his right foot to change directions, and then he felt a pain in his back and was unable to continue practice. The way he describes his pain, he gestures near T12L1 and also L4-L5 levels, and the right more than the left paraspinals as well. He stated that in his subjective interview, although it wasn't really indicated in the picture on the right. He describes his pain as sharp and constant. He denies radicular symptoms into his buttocks or lower extremities, and also denies his change in bowel and bladder functions. In terms of the behavior of symptoms, it is constant, like I said. On the VAS, he rates it from 2 out of 10 at best to 8 out of 10 at worst, and it is worse in the morning when he is more stiff and hasn't moved a little bit. The quality of his symptoms, the pain is sharp. Aggravating factors include higher intensity activity like swinging a baseball bat, which include rotating to the left, right-handed throwing, and sitting for longer periods. Easing factors include rest, moist hot packs, and e-stim prior to practice, which have been applied by his athletic trainer prior to this visit. He doesn't take any medications, not even Tylenol or anything like that. The proposed MOO, or mechanism of onset. So if we recall from the last slide, looking at the mechanism of injury, which was when the patient was performing shuttles at practice, if you look at the screenshots of these two men performing shuttles and the way that the patient described them, we can consider possibilities for the pain. So if you look at the pictures, we can see that there's lumbar flexion and left rotation with the right lower extremity planted when they are switching directions. Also, since he is a baseball player, it is possible that that could just have been the last straw, according to the reason for the pain, because it could have been a biomechanical problem all along. So if you look at that first bullet point there, we have a lot of twisting of the spine involved in pitching and primarily throwing and batting for him. And this increases the torque on the spine if you don't have the stabilization with the musculature around the spine. And the next bullet point is that the pain is located primarily in the transition zones of the spine around T12L1 and L4-L5, which is close to the sacrum. So if you look at figure 1 on the right there, we look at the facet orientation and review our anatomy. Looking at the thoracic spine, it's primarily rotation, and lumbar is primarily flexion extension. And so if there is less spinal stabilization, the forces are not transmitted as well, and so there's increased forces on the facets in the directions that they're not really made for, so that can increase pain. The next bullet point there is the possibility of tight hamstrings. So if you look at those pictures, of course the knees are a little flexed, but still if you have significant hamstring tightness, you can have increased spinal compensation. So you have to reach down and touch the ground. So you have the spinal flexion there, and then obviously the compensation there. If you look at the next bullet point, we have spinal instability that can cause pain, and the pain can cause muscular spasms in order for the body to protect itself, and that can generate more pain, and it's just an endless cycle. That fifth bullet point there, so we have trunk rotation that is needed for increased power of throwing and batting in his baseball activities, and so the pelvic and trunk rotation are also needed for elastic energy return, so that's just another consideration for another, mechanism of injury. And that last bullet point there is the possibility of the contribution of the previous slap lesion. Of course, it was just a type 1 treated conservatively, but there is a possibility that the deficits still existing in his shoulder mobility or mechanics could lead to compensation in his spine for generating the same amount of power needed for throwing and batting. Results of special tests and measures. So we started out with just some basic testing. Of course, we have some lower extremity strength testing listed there, and he was actually really, really strong. So there were no concerns in terms of lower extremity strength. However, we did have some active range of motion deficits, especially in left and right, or just left thoracolumbar rotation compared to the right. He did have pain with flexion and extension, as well as left rotation. Tests and measured continued. So with range of motion, considering the last slide as well, he had pain with flexion and extension, and he had a familiar pain with left rotation. If you look at his strength, like I said, he was pretty strong in all manual muscle testing of lower extremities bilaterally, and he had no issues with heel or toe walking. His sensation was intact bilaterally on both lower extremities, and his reflexes were normal at 2+. So we know that there's no significant, neurological involvement or red flags there. If we go on to special tests, he had negative straight leg raise tests. So I know that there's no neurological involvement there or no dural tension. A negative Kemp bilaterally, so there's no nerve root compression going on. And then a negative sacroiliac joint distraction and compression test. So there's no sacroiliac instability or no, referred pain there. He did have positive stork standing on the right lower extremity with extension, and that is the close back position of the spine, isn't an extension, so could have been some brief compression there due to some instability with the musculature around the spine. If you look at the next column, we look at joint mobility. In terms of the AP glides, we had some pain with levels T12 and L1, and also L4, L5 regions. And when we look at segmental rotation, he had some pain at L4, L5 on the right transverse process. Then, if we look at palpation, we had some tenderness to palpation along his right paraspinals, more than the left, primarily just the right, and moderate paraspinal muscular spasm on that right side primarily. He had no tenderness to his sacral borders. And if we look at hamstring flexibility, he was pretty limited with the straight leg raise hamstring flexibility measurements. He, on the left, was 42 degrees, and on the right was 50 degrees. And so that considering that he did have some difficulty with forward lumbar flexion, although he did have 60 degrees. Tests and measures continued. So range of motion was listed on the previous slide, but he did have pain with flexion and extension, and a familiar pain with left rotation. His strength was strong in his lower extremities bilaterally at 5 out of 5 with minimal muscle testing, and he had no issues heel or toe walking. Sensation was intact bilaterally in his lower extremities, and reflexes were normal at 2+ bilaterally in the lower extremities. Special tests done. So we had a negative straight leg raise test bilaterally for neural tension. We had a negative Kemp test bilaterally for nerve root compression. We had a negative sacroiliac joint distraction and compression test. So less instability there. And then we did find positive stork standing on the right lower extremity with extension. So if you look in the middle, there's more of a description on how that test is done, since we hadn't really gone over that in our coursework as much. So it's meant to identify pars interarticularis issues. So although, like I said before, nothing was found on the images, it could be so minor that it was imperceivable on those images. So it's just something to consider as we continue with his treatment. There could have been some minor stress there. He did have positive seated slump bilaterally for back pain, so some neural tension there. If we look at joint mobility, he did have some pain with T12, L1, AP glides and L4, L5 as well. And when we look at segmental rotation, he did have some pain with rotation on the right transverse processes of L4, L5. If you look at palpation, he was tender along his right paraspinals more than the left, with moderate paraspinal muscular spasm. He had no tenderness to his sacral borders. And when we look at hamstring flexibility, he was pretty limited here with a straight leg raise measurement. On the left, he was at 42 degrees, and on the right, he was only at 50 degrees as well. And he did have some difficulty with forward flexion as well due to this immobility. My clinic used FOTO, which stands for Focus on Therapeutic Outcomes, and it's a digital assessment system with the capability of giving us several health-based functionality measurements. So we really focused on the physical functional score primary measure, and my patient scored a 60 out of 100 on this, and the higher the number, the greater the function. And according to whatever the number they get, they are also given a stage. So stage 1 is lower function, while stage 5 is the highest function. And he's rated at a stage 4, so he exhibits little difficulty performing usual work or household activities and hobbies. Functional status. So when my patient filled out all these surveys at his intake appointment or initial evaluation, he said that he was limited a lot in vigorous activities. And the survey gave examples like running, lifting heavy objects, participating in strenuous sports. And he's limited a little in participating in recreation, moderate activities. And the survey gave examples of moving a table, pushing a vacuum cleaner, bowling, and playing golf. And also climbing several flights of stairs and performing his usual work, housework, or school activities. But subjectively, he did state that he functionally was most limited in playing baseball with his team and doing his regular workout routines at practice. Diagnostic hypothesis. So considering all of the things we have gone through so far with my case study, it is possible that although it wasn't, identified on imaging right now, he could have a pending pars defect or something, if it's not treated now, could lead to spondylolisthesis or spondylolysis, which would be very unfortunate. But, it is important to consider that possibility in the future if, he doesn't fix his body mechanics or address this problem with physical therapy early on. And also just considering the amount of baseball back injuries. On the next bullet point, you have functional spinal instability, which I can see why he would demonstrate that, as he was, tended to palpation with AP glides and rotations, as well as he demonstrated just poor mobility. And also he had decreased hamstring mobility, demonstrated by those measurements in the chart before. He also has probably a spinal muscle strain, considering that position he was in the shuttle position when he reached down to the ground in that forward flexion and left rotation. So there probably could be some spinal strain, especially on the right side in those erector spinae, perhaps the quadratus lumborum, the multifidi, which are also involved in rotation, perhaps the latissimus dorsi as it, attaches all the way through that mid and low back spine, and also the internal and external obliques as well. Diagnostic hypothesis. So considering everything we've seen in this case so far, although it wasn't particularly identified on imaging, there could be a possibility of a pending pars defect, which could lead to spondylolysis or spondylolisthesis at the extreme. So he did demonstrate a positive Stork standing test, which is for pars interarticularis issues, and he did demonstrate pain with extension. which puts the spine in the closed pack position and puts more force on the vertebrae and probably the pars interarticularis as well. As you'll find out later, the prevalence of back pain and spondylolysis with athletes and baseball players could be a possibility as well. However, this is not ruled in or ruled out particularly, but it's just something to consider. I do definitely think he has functional spinal instability. So he had pain with the AP and rotational glides. He demonstrates decreased hamstring mobility severely, bilaterally, and that could lead to compensation in the trunk, especially when looking at his mechanism of injury, touching the ground during the shuttles when he was changing directions. And also he could have some spinal muscle spasm or strain occurring as well. But as you'll find out later in my interventions, he did respond well to soft tissue massage and moist hot packs. So I'm thinking more spasm, as well as his pain was more on the right side. So he had pain on the right side with left rotation. So that tells me that the muscles on the right side are getting stretched a little bit out of that spasm. So that's probably what's causing the pain. If it were a strain, it would be the opposite. I think that he would have ipsilateral pain, so he would have pain on the right and also pain with right rotation if it was a strain. But some of the things some of the muscles that I thought were part of that muscle spasm reaction could be the erector spinae, the quadratus lumborum, multifidi, latissimus dorsi, and possibly internal and external obliques that are involved, especially with rotation. Okay, everybody, so I did some research, and Mr. Bill Nye over here is going to help us consider the following. First study looked at collegiate and professional baseball players and the prevalence of low back injury, and they found that the prevalence was about 8.3 to 15%. The second study looked at hamstring tightness and low back pain, and they observed that hamstring tightness could influence lumbar pelvic rhythm. So movement restrictions in the hamstrings or postural asymmetry could likely lead to compensatory movement patterns of the lumbar spine, and then as a consequence cause increased stress on the spinal soft tissues and an increased risk of low back pain. The third study looked at lumbar kinematics in baseball hitting and the history of low back pain. And they had two different groups, so they had a control group and a low back pain group, and the low back pain group had significantly smaller mean lumbar flexion angle and a significantly faster peak angular velocity of lumbar flexion throughout the swing. So they analyzed both the control group and the low back pain group in their swing mechanics, and so that's what they found. The fourth study, over on the right, looked at spondylolisthesis, spondylolysis, and the prevalence in baseball players. So of 6 Major League Baseball seasons, they took 272 professional baseball players with low back pain, and they all underwent lumbar spine imaging. And of those 272 players, they had about 75 of them that were diagnosed with the pars defect, so approximately 30% of them, which is pretty prevalent. Of those 75, 74 of them returned to professional baseball with a median return to play time of about 51 days. And those diagnosed with spondylolisthesis actually returned faster than spondylolysis, which was kind of surprising to me, but that is what the study had suggested. When you look at return to play time, the Major League Baseball players took less time to return to normal function playing baseball than minor league baseball players. And also position players took less time to return than pitchers. So it kind of addresses the different demands on the body in terms of mechanics, perhaps. And then finally, the last bullet point there, it says that lumbar pars defects were a common cause of low back pain. And the definition of a pars defect or spondylolysis is a stress fracture of the bones of the lower spine. These fractures typically occur due to overuse. They can be on one or both sides of the vertebrae, and it's a common cause of low back pain in children and adolescents, according to Washington University physicians. Impairments and disabilities in each area of function. Alright, so looking at pathophysiology, abnormal anatomy, and pathokinesiology. So we'll start with pathophysiology. So this is a screenshot from my musculoskeletal notes from back in the day, and We know that trauma, pain, inflammation, infection, emotional tension, cold, immobilization, things like that can all cause reflex muscle contractions, and that can lead to muscle spasms. So in terms of our case study here, we have some form of trauma during practice. He was performing those shuttles, and perhaps he had some instability going on, and he had decreased muscular control. So when he went down to touch the ground during that shuttle and quick change in direction, he could have had some muscle spasms as a reaction to that instability and lack of muscular control. So we have muscle spasms, and then what comes from that is restricted movement due to the pain and the spasming of the muscles. And then that leads to circulatory stasis, to the damaged tissue, and then that generates more pain. And then it's kind of an endless cycle that we learned. In terms of abnormal anatomy, we have no observed congenital abnormalities, but we do have a risk of spinal instability that could lead to spondylolysis or pars defect and spondylolisthesis due to repetitive or poor biomechanical motions if this were to continue or if he were to return to play too soon and not fix what is going on. In terms of pathokinesiology, so we have poor core strength and stability affecting his baseball swinging and throwing. We have to consider the transition zones of facet orientation. If we look at where he had the most pain was T12, L1, and L4, L5, which is close to the sacrum. It's more of the transition zones of the spine, which is kind of common in other athletes as well. Pain there is pretty common actually with gymnastics or ones that involve a lot of extension motions. So that could be attributed to that. When we look at his previous slap lesion, this could cause compensation in the spine in order to generate the same power. So if you have some deficits in the shoulder, so say a lack of range of motion or strength in the shoulder, you're going to try to generate that in the trunk and the hips in your baseball throw, for example. And so that can lead to compensation in the spine. And if you have less stability in the spine, not the musculature to support it, then that will lead to problems and pain. And one thing that I would like to do in the future, if I had the chance to work with him again, would be the chance to do motion analysis. Perhaps as he progressed a little bit more and we were more in the sport-specific training stuff, motion analysis would be kind of cool to look at to make sure that all of his body mechanics are correct. Interventions, treatment, and rationale. Okay, everybody, so we've got short-term goals and long-term goals. The first short-term goal is that the patient will be independent with his own exercise program to maximize rehab potential in 1 week. And then the patient will demonstrate increase in straight leg raise by 10 degrees, indicating an increase in hamstring length to promote proper mechanics during catching and throwing in 2 weeks. And then the patient will report no greater than 5 out of 10 pain at worst in his back, with activity to assist in returning to daily activities as a student athlete within 3 weeks. The long-term goals, the first one is that the patient will demonstrate increased lumbar extension and side bending range of motion by 10 degrees to assist with appropriate mechanics during hitting in 4 weeks. Then the patient will increase his left thoracolumbar rotation to be within 5 to 10 degrees of the right to improve mechanics of swing and other rotational movements within 6 weeks. The third one is that the patient will demonstrate a negative seated slump test indicating decreased neural tension to facilitate decreasing pain with activity within 6 weeks. And finally, the patient will report the ability to return to sport without back pain greater than 2 out of 10 in 6 weeks. Interventions. So we gave him a home exercise program after the initial evaluation, and we started off with some TA activation for that core stability. We added a supine march. We added a child's pose stretch, both anteriorly and anterolaterally, primarily to the left in order to stretch those right-sided muscles that are spasming. We added a seated table hamstring stretch to promote more mobility with that. We added a sciatic nerve glide because he had a positive seated slump test bilaterally in order to decrease that neural tension. And then we added a gentle lumbar rotation stretch in order to stretch those spasming muscles and as well as, promote pain-free movement and get out of that restricted phase. So for initial treatment sessions, we started off pretty heavy with neuromuscular re-ed, and then we transitioned more into Therex. So we started off with home exercise program, exercises, and then we added bent knee fallouts, bridging with the TA activation. We added dead bugs. We started off just the upper extremity first, and then we added both upper and lower extremities. We added the clamshells for that lumbopelvic stability. That will also help with the truncal rotation and stability during those twisting motions, especially in baseball. We added a cat-cow for that gentle movement, pain-free movement. It should have felt good to the patient, which it did. We added a gastroc stretch in order to help with that hamstring tightness that also crosses the knee joint. In terms of manual, we added a hamstring stretch using the contract-relax method. So we had that antagonist-agonist relationship in order to facilitate increased hamstring length. And then we had a soft tissue massage to his paraspinals, and we focused more on the right side. And he responded pretty well to that. We added modalities, which include moist hot packs and e-stim, which he reported in his initial intake paperwork that felt good when the athletic trainer had applied those things as well. So that was continuing to be beneficial. Progression of rehab. So we started off with a lot of patient education, neuro-re-ed, and manual, and then we transitioned more into just TheraX and therapeutic activity, more functional things. We started off in supine position, then we moved to a quadruped bird dog position, just using the upper extremities, alternating those, and then we added the lower extremities in there as well for more of a challenge. And then so from supine to quadruped, we moved to inclined movements and then standing movements. We moved from symmetrical things like mini squats in the mirror for visual feedback to more asymmetrical motions like lunges, upper extremity PNF patterns with the bands, simulating batting and working on that muscular control. We started off with static things like lunges on the floor to more dynamic and reactive things to lunges on the Bosu ball, for example. We started off with external focus. So when he was performing the bird dogs, we put a lightweight bar on his low back, like a wooden bar, like a foot long, just for some extra feedback, because he was required to keep that bar on his low back as he moved his upper extremities and lower extremities, so that would encourage more stabilization. And then after a while of mastering that skill, we removed the bar, and he was able to have better stability and just promote more internal cueing and biofeedback for increased motor learning. And then finally, we started off with some basic dynamic things like cardio, stair climbing, treadmill walking, and then advanced him to more advanced dynamic things like plyometrics, speed and agility drills, and then we would eventually progress to more sports-specific things like batting and throwing and, assessment of his mechanics there. Communication with the patient and other healthcare professionals involved. So initially we started out, like I said, with a lot of patient education and really getting to know the patient, doing a thorough subjective interview, and getting to know him throughout the sessions, building that rapport, as well as being able to learn his learning style, which is, was initially verbally, visually, lots of tactile cueing involved, but he is a well-educated college student, so there wasn't a lot of work that went into that. So in terms of communicating with other healthcare professionals, thorough documentation was definitely a focus to keep everybody, up to date and involved in terms of the patient's care. In terms of the athletic trainer, that communication wasn't as, as clear as I would have liked it to be. It was a lot of, the patient being the liaison between what the athletic trainer was doing with him and what I was doing with him. For example, the patient came in, after a couple of sessions, and I saw that he had evidence of cupping on his right paraspinals, and so, I asked him about it, and he said that his athletic trainer had performed that and that it was of benefit to him. So it was just kind of a thing that I stumbled upon, and I would have liked to have better communication with the athletic trainer in terms of how we're caring for the same patient at the same time, so that would have been more helpful. And then also referral to other healthcare professionals. There was really no need for that, considering kind of a straightforward evaluation, and there were no red flags to consider. And same thing with acquisition of adaptive equipment. That was non-applicable in this case. Outcome. So were the rehab goals achieved? I could say that he did make progression. Unfortunately, my internship ended prior to me having the chance to write him a progress note. So that was unfortunate. However, I know that he was progressing when I left. So for example, one of his goals was that he would report no greater than 5 out of 10 pain in his back with activity to assist him with his activities as a student athlete. And he actually had no pain at all after his 4th visit with us, so that was really rewarding. And he continued to progress in therapy without pain, so it was more so just challenging him safely each time without worrying so much about managing pain. So like I said, I didn't have a chance to write a progress note on him. One, because my internship ended prior to him having to have a progress note written about him, but also because about his 3rd week of therapy, he kind of started to cancel some sessions because he got busy with midterms and exams. Being a college student, sometimes it's a little difficult to come to therapy each week when you have such a busy schedule. He's also in a fraternity and all of these things. And also it was spring break for one of those weeks, so he was not present in therapy as much as I would have liked him to be. However, he was making significant progress, so that was really, really good. He was given a home exercise program his first visit, and then he was educated on how to progress that safely, and then he also was continuing to work with his athletic trainer. So essentially, were the rehab goals achieved? It's kind of unable to be determined on, which ones were completely achieved, but he was making progress. I would have liked to progress him into more functional activities, more specific to baseball, so he could return safely to his sport fully, and also continue to provide education on his body mechanics and his perhaps do some motion analysis. I think that would have been really cool too. So it's always good to give credit where credit is due, so shout out to all my references. Okay, everybody, so thanks for tagging along with me as I took a swing at this case study presentation. Hopefully you learned something and maybe you thought it was a home run. All right, have a good day.